So for today's Learning Community session, we're going to be talking about pharmacy prep. And we're lucky to have Dr. Maria Lopez here today with us. She's a pharmacy specialist clinician and a CBA specialist with the San Francisco CBA program. Dr. Lopez oversaw the implementation of hepatitis C point-of-care testing and one-stop PrEP at Mission Wellness Pharmacy. The first such community pharmacy program in California. Her work in community pharmacy aims to increase PrEP uptake and HIV prevention efforts in pharmacies, with a focus on populations not engaged in HIV care. She has published and taught pharmacists locally and nationally on the topics of PrEP implementation and testing in pharmacies. Dr. Lopez is also an assistant clinical professor in the UCSF Department of Clinical Pharmacy. So with that, I'll turn it over to Dr. Lopez. You're on mute.
Maria, you still need to unmute.
Is that better? Can you hear me now?
Yes, we can hear you now.
Okay.
Thanks.
Sorry about that.
No worries.
Good day, everyone. And I just have a question, Jesus. I am seeing on my screen pop-ups of people getting admitted into the room. Is that showing for everybody, or is it just something that I'm seeing but you're not seeing?
That's a co-host thing, so I can take that off for you if it's in your way.
Yeah, it might be good. It might be distracting while I'm talking, but
okay.
if you don't
How's that
need to
now?
do it,
I
that'd be
changed
great. Okay. Great.
Okay. You let me know if you need anything else.
Okay, thank you. All right, so good day. So I'm going to talk about the PrEP landscape with pharmacy today with a focus on the Western region. And the SF-CBA program provides capacity building assistance for HIV testing and prevention in the Western region. And here on the screen is our contact information and website. So today I'm going to talk about the PrEP continuum and how pharmacists play a role in the PrEP continuum. I'll go over, review the pharmacy PrEP landscape and discuss pharmacy models specifically in the Western region. Today's objectives are to review the pharmacist's role in the PrEP continuum, provide an overview of the pharmacy PrEP landscape in the US, again, focusing on the Western region, identifying barriers to implementing pharmacy PrEP programs, and finally end with discussing objectives that health departments and community organizations can take to partner with pharmacists to increase access to PrEP, and I should say PrEP and PEP. Pharmacist scope of practice is varied. It's regulated by each state board of pharmacy. So we have 50 states in the US and 48 states and the District of Columbia allow pharmacists to enter into collaborative practice arrangements with physicians or another provider. So that means that 2 states do not allow pharmacists to enter into collaborative practice. Under collaborative practice, pharmacists, and depending on state protocol, because of the different regulations in each state, most pharmacists can initiate, monitor, and modify therapy. Pharmacists also deliver a number of preventative healthcare services. And so here on the screen are a list of some of these preventative healthcare services, and the majority of these fall within almost all pharmacist scope of practice in the United States. The pharmacist can do blood pressure screening, cholesterol, diabetes. These are just examples. Help with weight and obesity screening and counseling. We can also help with tobacco cessation counseling, as well as in some states initiate tobacco cessation products. They also provide, majority of states allow pharmacists to provide CLIA waived testing. Examples, so CLIA waived is rapid testing, so they can provide a rapid HIV test, for example. Hepatitis C would be another rapid test. Very common rapid test is for glucose, for diabetes. And then one that we are probably most familiar with the recent pandemic is the COVID testing that many pharmacies did in the Western region of the United States. Another important preventive health services that pharmacists have provided for some time now are vaccinations. And pharmacists have played a critical role in providing vaccines and in helping to increase uptake of vaccines in the United States. Again, most recently with the COVID pandemic, we saw that pharmacists provided over half of the vaccines in the United States to persons in the US. The HIV PrEP care continuum, as described by the CDC, is listed here. And these steps are awareness, uptake, and adherence and retention. And pharmacists can play a role at each step in the PrEP continuum. So they can help with planning and implementing strategies and programs, utilizing their skills and their expertise to work with other healthcare providers and organizations. They can also educate populations and providers about PrEP, particularly as being experts in medication. They can help with the medications and also the disease state. By educating and also testing, they can identify and engage individuals who are at increased risk of infection. Pharmacists can also help with uptake by either linking patients to PrEP care or prescribing or starting PrEP. In California, we use the word initiating for prescribing, but the CDC separates prescribing and initiating. So in this slide, we're talking about prescribing, as in prescribing, and then initiating to starting PrEP. And pharmacists have played a role and can continue to play a role in helping patients get started on their PrEP medications. As I mentioned, pharmacists are the medication experts and have been able to, among a number of disease states, to show very positive outcomes when pharmacists are involved in adherence. So they can help patients to be adherent to their medication. And ways that they can do that are by educating them, also providing tools to help with adherence, such as reminding them of, doing an assessment with the patient and talking to them about how is PrEP going to fit into their life best. What would be the best way to help them so that they can continue to take their medication and stay HIV negative. We also know that they can help patients stay on PrEP. And we have some data from one of the pharmacy models that I'll talk about in a few minutes, where they had very high adherence rates. And so that model was really important in showing that pharmacists can help patients to stay on their medication. But we've seen pharmacists play a role in adherence and retention across many disease states when it comes to medications. Federal partners support the use of collaborative practice agreements and state protocols. As I mentioned, pharmacy scope of practice varies by state, but our federal partners do encourage the use of protocols and state-based protocols and collaborative practice agreements to increase medication access. And here is an example of a directive letter that was sent in 2017, specifically by CMS and HHS, to encourage states to help with timely access to medications by expanding pharmacy scope of practice, utilizing collaborative practice agreements or other determined protocols or standing orders. Additionally, the Surgeon General has also, in addition to CMS and the CDC, have recommended the use of state-based protocols to increase access to medications in order to improve patient care outcomes And so I just wanted, you to know that it is something that federal partners are looking at. I'm going to talk about some of the barriers, but we do have support from federal partners in this initiative for pharmacists to be more involved in HIV prevention. In 2019, California was the first state in the country to pass a PrEP and PEP specific bill that allowed pharmacists authority to initiate, and again, when I mentioned earlier that we use the word initiate in California, which is to prescribe PrEP and PEP. The bill that was passed, SB 159, permits California pharmacists to initiate up to 60 days of PrEP within a 2-year period and 30 days of PEP. For PEP, there is not a one-time in 2 years. There's no limit there, so it could be multiple times. However, we'd want to follow CDC guidelines and ensure that the patient, if they were using PEP multiple times, would consider initiating PrEP because PrEP may be, a better option for them in the long term. But there is no limit on the PEP. The bill also mandated that the Medicaid program in California, called Medi-Cal, reimburse pharmacists for their time for initiation. And the bill prohibits prior authorizations on PrEP. Some of the barriers to this bill are that the 60-day limitation, one, was not in line, is now currently not in line with CDC guidelines, which recommends 90 days at initiation. Additionally, the 60-day limit really limits pharmacies from implementing PrEP because it's a one-time 60-day initiation, and there isn't an incentive to provide ongoing PrEP. Other states have since passed bills, and I'll mention those in the next slide. Additionally, one of the big barriers was the financial. While it did mandate that the Medicaid program reimburse pharmacists for initiation just for the time, it did not cover or mandate testing. So there is no mandate in California for pharmacist ordered tests to be reimbursed. And that's been a big barrier because pharmacies have not been able to justify providing those tests without the financial support for them. Additionally, because it's so limited, the one-time 60-day without a financial incentive doesn't really provide a model to support ongoing services. And there's a lot to start PrEP. It requires, as I mentioned, the testing, but also that staff are supported, that pharmacies can cover staff cost, as well as the education that is needed to educate the staff. And education for pharmacists remains low still, although it is increasing since the bill passed. But we saw prior to 2019 from a number of studies in different states that overall education for pharmacists in terms of the awareness of PrEP is low, very similar to what we see on the medical community with physicians and nurses. And that's because these medications were only available, since about 2013. And so many pharmacists have not been educated on these medications. And when we have low education for providers, that means that there's less awareness for our patients. Our pharmacies are really an ideal access point because they're so available in the community. We have pharmacies everywhere with in the community with longer hours, and they're open on weekends and evenings as well. So they really can provide, a place for patients to go to, particularly when they can't have access to a medical provider, which we know that there's a shortage of medical providers. Regarding SB 159, I will say that we recently put through the legislature, and I say we because I've been working with the advocates to put a bill through the legislature that would fix SB 159, and that's SB 339. That bill did get passed in the Senate and the House, and it was just going through the final committee before it went to the governor's office. However, what they call a kill language was added to the bill, and the language was specific around the prior authorizations. And so it has currently been pulled from the legislature. But that bill would have removed the 60-day barrier, would have changed it to be 90 days in line with CDC guidelines and what other states are doing. It would also have mandated payment by all insurances. That bill was recently pulled. It's not completely dead yet, and there is potential that it could come back into the legislature in the near future. The pharmacy advocates have also put a different bill through, which looks like that's going to be signed by the governor, and that's AB 317. And AB 317 will mandate payment for all clinical services by insurance companies. And so that won't be just specific to PrEP. And from what I've been told, it looks like that bill should get signed by the governor, we hope, in the next few weeks or days. And then that would help with specifically the payment. However, we still have the 60-day limit in California under SB 159. So unless SB 339 is corrected or there is a fix-it bill to that, we will stay with the 60-day limit for pharmacist initiation of PrEP. However, pharmacists in California can provide PrEP and have been able to under collaborative practice agreement. This is a list of the Western Region Pharmacy PrEP Authority. And so numbers 1 through 7 are the states in California in the Western region that have passed specific legislation around PrEP and PrEP. So specific prescribing authority for PrEP and PrEP. All of these states, except for California, allow 90 days of PrEP and PrEP. And many of them, the majority of them, allow ongoing PrEP. They also have put into their bills broader payment mechanisms. So some of the states that we're seeing now, Nevada, for example, Colorado, and Utah have started to implement their programs. We know that in Nevada, they are billing for medications and initiation for pharmacists, and as well, we're seeing that in Colorado. So while California was the first state in the country to have a PrEP and PEP specific bill, we have other states that have fortunately surpassed us and are implementing their programs in their respective states. Washington is listed below in bold. It is a state among other states in the US. I don't have all of the states in the US listed on this slide. I was really trying to focus on the Western region, but I did want to highlight Washington because a number of states with Washington included allow pharmacists to prescribe PrEP and PrEP with more broad authority. Because as I mentioned earlier, and I keep saying this, is that scope of practice varies by state. So Washington has had for a number of years now a broader authority to allow pharmacists to basically create a protocol. It does need to be with a physician, but that protocol allows them, it's much different than collaborative practice scope that we have in California. It's a little bit broader and easier to implement. And so Washington has had that authority, and that's what I would call more broad, indirect authority for prescribing PrEP and PEP versus the 7 states that are listed here that have passed specific PrEP and PEP bills. I'm going to move now over and talk about our program at Mission Wellness Pharmacy. In 2018, we launched a collaborative practice agreement with the San Francisco Department of Public Health. It is a collaborative practice agreement where there's a lead physician, and that is Dr. Stephanie Cohen, who is in charge of STI and the City Health Clinic. And she is the lead physician under our collaborative practice. And then we have a lead pharmacist, which I am still in that role. And so we launched this collaborative practice agreement. The health department did provide some in-kind support, and they had some limited funding that we received back in 2018 to help with building out our clinic. So we built out our clinic, and then they helped us by supporting us with computers and laptops, iPads, so that we could put in an EMR system. We also had some advertising with the San Francisco Department of Public Health. It took about 20 months, and we did publish a paper on the implementation of our PrEP program. It was launched in April of 2018. And the reason that the health department did work with Mission Wellness and choose our site was because we're in the Mission District of San Francisco, which is historically the Hispanic, Latinx, Latino area of the city. And there are health disparities in HIV in San Francisco, like we see in the rest of the country. So Latinx individuals make up a large percentage of, a disproportionate percentage of HIV positives, and also are also disproportionately represented in uptake of PrEP. So for that reason, we launched our program in 2018. As I mentioned, we did publish an implementation paper. I think I have a slide on it, so I'll talk about that in a few minutes. The way that our program works, and this is sort of the general scheme. I will say that with COVID, we did have less in person, and so we kind of adopted a little bit of a hybrid model. But in general, we follow the steps of our intake. Patients always complete an intake questionnaire. When we first started our program, we were on paper, and then we moved to an EMR. So they completed on an iPad. So they do the intake questionnaire, questions around their insurance, their demographics. We also ask about number of partners, any drug use. And so we gather all that information. The pharmacist can then review that, and we have benefits navigation that occurs by our pharmacy technician, who serves a role as a peer navigator. And so our pharmacy technician will do the benefits navigation and then reach out to the patient prior to them coming to the pharmacy. Or if they walk in and are at the pharmacy, they would do it, with them at the pharmacy. The advantage of doing this in the pharmacy is that because we have a pharmacy system, pharmacies, as you know, when you go to the pharmacy, you have to wait 15, 30 minutes to pick up your medications. And that's because not only are we inputting the information, but we're also adjudicating it or billing it directly in real time to the insurance company. And so that's one of the advantages of starting PrEP in a pharmacy, is that the staff can in real time do the benefits not navigation, but also adjudicate and ensure payment for the medication, or sign them up and enroll them in medication assistance programs if needed. So that's all done before we actually see them in person. Meaning the pharmacist sees them. So whether they're at the front counter or they've made an appointment and we're going to have them come in the next day or in a few days, we would do that intake. The pharmacist, as I mentioned, reviews everything, then interviews the patient, and will order labs as appropriate. A lot of times we get the labs ready beforehand, but we just confirm before we have the labs collected and ordered for the patient. During the visit, we do a rapid test, and the patient is given either PrEP or PEP. We do assess for PEP. We think it's very important to assess for PEP with PrEP, because we know that some patients should be getting PEP instead of PrEP. but we give them the medication, and that's done after the rapid HIV test comes back as negative. Then they would get their medication, and our staff will follow up with them on their follow-up appointments and their refills. And depending on if they can get 90 days or they need to get 30 days due to a 30-day limit with their insurance company, our staff, our technicians follow up on their refills and monitor them. And they would notify us, a pharmacist, if patient doesn't pick up their PrEP or is late on picking it up, so that we could provide counseling. So the visit, time, the initial appointments are longer. They can take 30 minutes, but they're, including the labs, 45 minutes to an hour. I didn't mention, we do have either a phlebotomist or a nurse on site. We've tried both. We were using just phlebotomists, but during COVID, we had nurses on site we were doing a number of COVID tests and vaccines. So we done a hybrid with phlebotomists and nursing staff. The visit is a complete medical visit with a social and financial assessment, as well as the labs. So people have asked, what tests are we doing at our site? So I've listed them here. We do the Alere Determine HIV Antigen Antibody Rapid Test for HIV, and then for hepatitis C, the OraSure test is what we're using for rapid. And both of those tests provide results within 20 minutes. We have been, since inception, providing HIV RNA. So even though we've always done the rapid test, we've also always done the HIV RNA test, which is now recommended by CDC, optimally recommended. And then the other tests are a lab-based serum creatinine, Hep B, surface antigen, gonorrhea, chlamydia, syphilis, and we do 3-site testing for STIs. Depending on results of any of these tests, we can provide, we can order follow-up test. So if we have a rapid antibody Hep C, we would then do a viral load of hepatitis C to confirm the patient for infection. And then for women of childbearing age, we do for a rapid pregnancy test at each visit. So I mentioned, we started our program in 2018. The pandemic started in 2020. That did put a big wrench in our program because our focus, not only were we limited in seeing patients in person for a short period of time, but we were also really focused on COVID work in testing and vaccines. And there's been changes in the state of California with the Medicaid program and reimbursement for medications. And we have not received any reimbursement for our staffing cost. And so our program has been limited. I'm not gonna talk about the data, but I do have that in another slide. So let me just talk about this survey in California that was completed for our 9 pharmacies recently, and it was published last year, and just talked about some of the barriers that they are seeing with pharmacists in California. And so the barriers that pharmacists brought up with SB 159 were the limited supply. Really, as I talked about earlier, prevents ongoing PrEP, the financial, which I've talked a lot about, the cost burden to implement the program, as well as the high cost of medications, really makes pharmacy-based PrEP in California very difficult at this time to implement on a broader scale. Because pharmacists are not paid, they don't really have the time, or companies are not focusing on staffing for initiating PrEP and PAP. Additionally, pharmacists are not getting the education, but also patients don't have the patient awareness of it. So the pharmacists that were interviewed are not seeing patients asking about PrEP or PAP or being aware of it. Interestingly, there's also among these 9 pharmacies a perceived lack of need. So the idea that, well, there really aren't patients in our community that need PrEP or PAP. And this really is in line with more of education for pharmacists, because when these were Bay Area pharmacies that were interviewed, and we see that in California and also in the Western region, where there is a perceived lack of need among pharmacists, but also other providers, and one of the barriers that we've seen with PrEP in general. Another barrier that was cited is the lack of access to laboratory testing. As I mentioned, they're not reimbursed at this time. Pharmacists can sign contracts with labs, outside labs, and can access laboratory tests, but there's this perceived lack of it. Out of the pharmacies that did mention the perceived lack, 5 of the 7 did report overcoming this barrier and setting up either rapid test or a partnership with a lab or a clinic. So it does seem to be more of a perceived lack versus an actual. All right, so now on to some of the data. This is a number of sites that in the Western region, primarily. I did put the Virginia one just because that's a really interesting one. So the first one, the San Francisco Mission Wellness, is from our implementation paper. In the first year, we initiated 51 patients on PrEP and 6 patients on PEP. As I mentioned, our program was started to focus really on increasing PEP and PrEP to the Latinx community. We found that out of our 51 patients, 24 or 47% identified as Hispanic Latino, which is the CDC definition. So almost half of patients in our program have identified as Hispanic Latino. What's noteworthy about that is that in San Francisco County, the percentage of Hispanic Latinx is much lower. It's around 17%. So we're seeing about 3 times that percentage in our pharmacy. So our pharmacy is accessing Hispanic Latinos. We also had 10% who identified as African American, or 5 patients. San Francisco County also has a very low demographic for Black African American patients. It's 5%. So we're seeing double what the county demographic is at 10%. I will say that the majority of our patients are MSM. From our initial data, 82% identified as MSM. Since our program was implemented, we've initiated PrEP on over 250 patients to date. As I mentioned, we have struggled with keeping the services. There was a period where we didn't have a phlebotomist, so that really hurt our program. And then just dedicating time with all of the COVID testing and vaccines. We do see that San Francisco is a very mobile city, so people come in, they need PrEP for a short period of time, either because they're moving into San Francisco and then they move out, or they're in between with their jobs and then they get a job and have to use a different provider for PrEP, or they have insurance so they can go to a private physician at that point. I mentioned that I was going to talk about Virginia, even though it's not in the Western region, and I just like to talk about this model because it was a model that CDC funded in the state of Virginia, and it was a collaboration with the Walgreens pharmacies in 32 locations where there was high need. So patients had it was by census tract, and they had to have majority percent of patients that were either Black or Latinx. So 32 pharmacies were identified by the census tract and were part of this initial study that was CDC funded. And in a 2-year period, back in 2014 to 2016, the pharmacist performed at 32 locations around 3,600 HIV tests. And these were rapid, they were actually oral tests, which are not the preferred tests, but they were performed at the pharmacy by pharmacists, and they saw a 0.8% positivity rate, which is what we see in the real world. What's notable about this is that a large percentage of the patients, and it was almost half, had never had an HIV test, and so I think that's really notable that when we identify areas of need where there are high percentage of patients that are Latinx or Black, or they were at or below the federal poverty level, which was the requirement, they were able to identify, to provide for the first time HIV tests to a large percentage of these individuals, and also demonstrate that HIV testing could be done in pharmacies. So I think that's what's really notable about this study. The next study below is the Kelly-Ross Pharmacy in Washington State. And that's really the gold standard and seminal study that was published and presented, has been published and presented on pharmacy PrEP. So this program is a private pharmacy with a private physician in the state of Washington. I mentioned earlier that Washington has broader collaborative practice laws for pharmacists in that state. So they started the program in March of 2015. Also, what was really key for their program was that simultaneously a bill was going through the legislature, which was the first bill in the country that mandated payment for pharmacist services for any clinical service by a pharmacist. And that bill was passed in 2015 and went into, was active January 1 of 2016. So the combination of their collaborative practice laws, as well as the first bill really in the country that mandated payment for pharmacists, really supported this site to provide a large number of patients. The results here are from a 2-year period. And so they evaluated 714 patients. I think there was a little under 700 that actually started PrEP. They had a very high, what we call adherence measurement. PDC is proportion of days covered. And that's a pharmacy measurement that looks at pharmacy refill data. And that's used to measure adherence in the pharmacy side. So from an industry standpoint, PDC is what is used on the pharmacy side. And insurance companies will also use PDC, proportion of days covered. And 90% of their patients had a PDC greater than 80, which means that they had adherence. So we have a very high percentage of patients in this study with high adherence. They also had what they reported was an effective dropout rate of 25%. So effectively meaning that 75% of their patients were retained in care. And that was something that really raised eyebrows, because PrEP retention has been something that we've struggled with in the PrEP community, in the medical side, in clinics. And to see a pharmacy have very high adherence and high retention really brought attention and raised eyes to this idea of pharmacists providing PrEP and PEP. So those are kind of the main points of the Kelly-Ross, which I would say really is the gold standard and the biggest study to date on pharmacy-based PrEP and PEP. There's another smaller study that was published out of New Mexico, and they just looked at EMRs. This was the outpatient pharmacy that was connected to the University of New Mexico Hospital outpatient pharmacy in Albuquerque. And pharmacists initiated PrEP and then followed up on the monitoring. So through the EMR review, and it was just a 2-month review, they had 127 patients started, and on average, patients missed less than 1 dose per month. So we're seeing really high adherence here as well. I'm just going to quickly mention, I know I mentioned earlier that federal partners are supporting PrEP and PEP. NIH and CDC recently hosted a research symposium titled Pharmacy-Centered HIV Research, Current Landscape and Future Frontiers. And it was a virtual training over 2 days that brought together pharmacists, researchers, community members, and federal partners. And there were a number of presentations. It was really centered on the evidence-based research and pharmacy-centered HIV testing, care, and prevention, and also to identify future recommendations. The approaches focused on health disparity populations, addressing HIV-related comorbidities, and how to leverage HIV trainings for pharmacists pharmacy students and also to facilitate research. I would say that there were a number of models that were presented. Kelly Ross did present at this symposium, but key highlights that were, and these were bullets that were put up, was that National AIDS Strategy recognizes the role of pharmacists in supporting the end of HIV. And they also recognize that we need better coordination and involve agencies, pharmacies, and community leaders. And so, to really emphasize how pharmacists and pharmacy workforce can be initiators and leaders in collaboration in the public health space. This is just the beginning of what the federal government is looking at, but we know that they're very interested in this, and we see that through CBA. At the NIH symposium, a number of models were discussed. I mentioned the Kelly Ross model was presented. There were also some chain pharmacies that have presented where they are in starting to support pharmacy-based PrEP and PAP, as well as the Kelly Ross model. And then there were some models in Africa, in Tanzania, and gosh, I'm blanking on the other country. It was 2 African countries where there is some promising data, showing in Africa that pharmacists can play a role in HIV testing and in helping patients to initiate PrEP. So in summary, I think that the successes are that pharmacists can initiate PrEP and PEP, and they can help to increase uptake, given that they are an additional provider and that there are many locations that could be added to provide additional locations for PrEP and PEP. From my experience, patients do appreciate the service. I've heard this also from Kelly Ross, that just being able to go to one location, get your test, see a provider, and pick up your medication is really convenient. It decreases the barriers with the number of visits, and also facilitates same-day PrEP, which we know helps with adherence and retention, based on, as we saw in the pharmacy data from Kelly Ross, but also what we've seen in the non-pharmacy data in the HIV PrEP space. The challenges for pharmacy-based PrEP in the Western region remain the reimbursement challenge, specifically in California, and then some of the states that are just starting to figure out and implement their reimbursement. Even though they pass bills, there's still there's a delay, and insurance companies recognizing pharmacists to pay them. I should note that pharmacists are not recognized at the federal level as providers by CMS, and so that's been one of the big barriers. And the federal government is aware of that at this time. And I talked about the lack of coverage for testing, and the training is not widespread. I believe this is my last slide. I know we have some questions that we put up, so we should probably leave some time for questions, and these are the references.
Thank you so much, Maria. That was really rich, and it was great to hear about the pharmacy PrEP landscape, as well as the Mission Wellness implementation experience. And if folks have questions, feel free to put them in the chat or to raise your hand. I see there's a question about which rapid HIV test you used. I know you answered that question, but if you had anything else you wanted to add about that in terms of how you decided on the test that you used.
Yeah, so I had this slide up, and I could put it back up. I don't know, Jesus, if you were going to put up the follow-up questions. But I can put up my slide again with
some guiding questions in the chat, but if you want to bring up your slide,
okay,
Maria.
yeah.
Go ahead.
So the allele determined is a rapid, it's an antigen antibody. Oh, that's an error there, I should say. I didn't catch that. It says antigen, so the antigen antibody AGAB rapid test. We use that test because our health department is funding our test, and that's what they use, and a couple of the other larger sites do when they use a rapid test. It can have a false positive. It's about 99% sensitivity and specificity. So it is a pretty good test. It provides, the results in 20 minutes. And then we're using the OraSure HCV rapid antibody test for Hep C.
Thank you. We have a question from Taylor Holsinger in Alaska. What are the initial 45-minute intake appointments, or rather, where are they being held? And are pharmacy staff doing the intake, blood draws, and follow-up?
Yeah, so the intake appointments, all appointments, intake and follow-up are completed at the pharmacy by pharmacy staff. We do have, well, right now we don't have a phlebotomist, but we have a nurse on staff. So we have used either a nurse or a phlebotomist over the last 5 years for the blood draws. And they are staff of the pharmacy.
Thank you. And do you have a separate space in your pharmacy for those visits, those PrEP visits?
Yes, we do. I didn't mention that our site, so we had we've always had a very small consultation room, but we were fortunate enough to expand in our site. We had a space next door that became available, and we took over that space and put in a number of consult rooms. So we have specific consult rooms that are like what you would see at a physician office, and that's where we see our patients.
Thank you. And if folks have other questions, feel free to put them in the chat as we move along. We have some guiding questions for today. Oh, go ahead.
I see a question here. Oh, so I want to further elaborate on the lab base. I see another question about lab. So our health department is paying for our test. And the way that our tests work is that the rapid tests we do on site, our lab-based tests are sent out to the public health lab, and San Francisco Department of Public Health also contracts with an outside lab. Just because of cost reasons, they decided that our serum creatinine and Hep B test, for example, we're going to go to an outside lab, but then the other tests, HIV, the STI test, those all go to the public health lab, and we have a courier that takes those over to the public health lab where they're processed. So we're not paying for the test. It is a collaboration between our health department and the pharmacy. Our staff do have to prepare the labs, draw them, collect them, and label them to send them out to the different labs of public health, and then the contracted outside lab for serum creatinine. And then we have to follow up on those results as well. So our staff are following up.
I see Richard Salazar, you have your hand raised if you want to go ahead and unmute and ask your question.
Hi, yeah, thank you. I just didn't know how to type it out. So I want to go back to the Alere test that you said you're using. So basically, I think you also mentioned it's whatever the health department uses. So if we theoretically say we were going to provide tests to a pharmacy, could they use InstiTest as long as a viral load or another what is it, not the RNA, the antigen antibody test is being drawn on the same day?
Yeah, I mean, the thing about what we recommend for pharmacies is that really using the clinical, the CDC HIV testing non-clinical site testing for HIV testing. So obviously, the more sensitive, the more preferred. But CDC does recognize that cost does limit sites. So whatever your health department determines is the test that you will use for rapid testing, I think would be fine. Lab-based testing would also be highly recommended as a backup. And then also, to ensure that the pharmacist, if it's a collaborative practice or you're going to be working with pharmacists in your community, that they are following the guidelines and assessing patients who, for acute HIV or recent exposure to HIV, right? Because that also determines what test should be used, whether they should have an RNA test.
Perfect. Thank you so much.
You're welcome.
Thank you. And we have some guiding questions here. And I know that there's lots of folks in attendance who are working in this area around collaborating with pharmacists and pharmacy services. If anyone wants to jump in and share their experience about how their jurisdiction is including pharmacists in HIV prevention and workforce development, would love to hear from them. Preston, I know that Nevada has been doing a lot with partnering with pharmacists. If you wanted to share about your experience, would love to hear that.
Yeah, Nevada has recently did a partnership with Walmart Specialty Pharmacy in order to increase access to PrEP and PEP. Especially during our 2021 legislative session, we expanded the scope of practice for pharmacists to also prescribe PrEP and PEP. So they recently started offering their services in especially in the Las Vegas area, and hopefully we'll expand in Northern Nevada as well. But the fact we built this partnership with Walmart in order to push out additional services, which is absolutely phenomenal. And then they actually put in the Walmarts in our high morbidity zones. So it's been a really profound effect in that matter.
That's very exciting. Thank you for sharing. Do you have any advice for jurisdictions that want to partner with pharmacies or chain pharmacies about from your experience?
I would say, of course, developing that partnership as well as creating that buy-in is always vital and important, just because if they don't know about it, then how do they feel like they're part of creating that change? So I actually take the time to speak with all of our pharmacists as much as I can from my role to push that narrative forward and be like, yeah, let's go, and how they fit into overall ending the HIV epidemic plan as well. So it's been really cool.
Very exciting. Well, looking forward to hearing more from that program. Very unique. Do others have experiences that they would like to share with partnering with pharmacists in their community? Ashley, were you raising your hand?
Couldn't find the raise hand button. Sorry. I could share something briefly just to add to the comment about Walmart pharmacies. We have a different group of folks that are working on, so pharmacists prescribe PrEP and PEP is allowed in Oregon by the Oregon Board of Pharmacy. And there are folks like working on getting buy-in from chain pharmacies, retail pharmacies, to get pharmacists to prescribe. And so I've been kind of involved in that, but not really in the meetings with those like administrative leaders. But I did get in contact with Walmart as well. I think their community liaison, or I forget their title, but they were very interested in supporting HIV prevention work, which I was surprised to hear, only because they were like, what can we do? Like, what do you need? And they actually helped us start putting together, they gave us all their information about which pharmacies across the state stock PrEP and PEP medications. And they shared all that information with us. So we were able to create a database for patients on where they could go to find PrEP and PEP. And we plan on doing that with other pharmacies as well. But the Walmart was the first one to say, yes, we want to be involved. And they also were willing to stock PEP medications in places in rural areas of the state where there weren't any pharmacies that were stocking those medications. And so they said, okay, at these sites, we will stock PEP medications and you can put it on the website so that patients know that we will continuously stock these medications. And I think in my conversations, I think they said, you know, we have a really strong brand identity with folks in rural communities. And so I think there's a lot of interest in supporting HIV prevention work in rural communities. At least our community liaison said so, in places where there aren't other options. And so it might be just worth reaching out to commercial pharmacies and having conversations instead of reaching out to individual pharmacists that don't necessarily have that decision-making power.
Thank you for sharing that experience. Really interesting to hear how you're able to get vital information about medication stocking. There's nothing worse than having someone show up at a pharmacy and not be able to pick up the medications they need.
Sure.
Do other folks have questions? Oh, go ahead, Maria.
Oh, I was just going to add, from the NIH CDC symposium that was recently that I put up a slide on, that they did, Walmart and CVS did have models that they talked about. There was a researcher from USC that discussed pharmacy desert, and some of the talk around that was that one of the things that we need to be thinking about with pharmacy-based PrEP and PEP is that we are seeing some of the chains get involved, which is great, but we want to be careful that we don't further perpetuate disparities that we've seen, because one of the things that stakeholders should be looking at is where these pharmacies are located, because they're often located in larger rural areas, but not small rural towns. And so that was just discussed at the symposium as more of to be aware of, for organizations that are being involved in this, because we do not want to worsen PrEP access disparities by providing PrEP in areas where PrEP is already being provided, but looking more at areas where PrEP is not being provided. So I just wanted to bring that up since it was discussed.
Thanks for that, Maria. And as an independent pharmacist yourself, do you have advice or recommendations about reaching out to the independent pharmacy community?
Well, from my experience, the best way to do that is through the organizations, unless you can identify, somebody who is in the community who would has access to other independent pharmacists. I do think it is, until payment is worked out, it's interesting. I mean, the studies that have been published so far, there's a few, they've all been in independence. We haven't seen the chains move in to publish studies yet, but I think that that's starting to change, because we're seeing, interest from some of the chains, not all of them at this point. And I would say in 2016, I was involved in a roundtable with a number of pharmacists across the country, primarily chain pharmacy leaders. And at that time, they were saying, we're not going to do it until, we're paid. So I think we need to get both, for sure. We need to get independent and chain. We need both. We need chains to be involved, but we also need independents too, just because of the small rural areas where there are not large chains. Chains typically focus on populations. They will not go into an area unless there's 50,000 residents. So that's where the small rural towns get left out.
Thank you for bringing that up, the role of pharmacies and addressing some of those geographic disparities as well in access. Do we have any last questions for Maria or folks who want to share about their experience working with pharmacies? I see a Megan Cannon raised your hand.
Yeah, and I'll turn my camera on, sorry. Yeah, I think, so I work at the Colorado Department of Public Health, and in Colorado, pharmacists are allowed to prescribe both PrEP and PEP amongst other kind of for UTIs and like other things as well. One of the things that we found super helpful with connecting with pharmacists was working with our Colorado Pharmacy Society. So in Colorado, as I'm sure in like other states, like professional affiliation groups have been really helpful for us to just kind of get to a group of pharmacists and like figuring out who is interested in doing this type of work. And talking with kind of like large groups of people versus going individually. Because, you know, we've talked with the Walgreens, we've talked with like other chains and stuff, but we found a lot of more productive conversations in kind of those group settings to just kind of hearing what the challenges and barriers and successes are from a policy and infrastructure standpoint for getting pharmacists the ability, you know, I think they want to do it, but I think to what Maria was just talking about, the infrastructure just isn't set up to do that. So figuring out how we can help fill in some of those gaps from a health department standpoint.
Thank you for sharing that. Anything to add to that, Maria?
No, I think that's, yeah, I think that's great. You know, the local associations, you know, are one area. I think also advocating at a national level, there is talk of recognizing pharmacists, especially after the COVID pandemic. So if, you know, states have an opportunity, or stakeholders have an opportunity to advocate for national recognition of pharmacists, I think that will really help speed along a lot of these barriers that we're seeing.
Any additional questions for Maria or experiences that folks would like to share? If not, or if folks are taking a minute to type something in the chat, maybe we can share our evaluation. I think Sophia put it in the chat. We really appreciate your feedback on this session today. And in particular, some of you all who worked with us on jurisdictional plans indicated an interest in implementing pharmacy prep. So if there's interest in an additional session with more of a deep dive on a topic around pharmacy prep, we're interested in organizing it based on your feedback. So in addition to getting evaluation, we'd love to hear what you'd like to see for a follow-up session on pharmacy prep. So thank you for taking a couple of minutes to complete that. You can use either the QR code or the link in the chat. And if folks have additional questions popping up, we still have a couple more minutes as well. Otherwise, we'll give folks time to complete the survey. And while they're doing that, just a big thank you to Maria for taking the time to share your expertise with us and your experiences. And maybe we can give some reactions for Maria. And please do reach out to us at the San Francisco SEBA program with any questions, or if you'd like to work with us on partnering around pharmacy prep. All right. Well, thank you again for coming today and sharing your experiences for those who spoke up, and appreciate again anyone who's able to complete the survey. We value your feedback and always trying to be better and bringing together the West region. And we'll end early today. Take care, everyone. Have a great day.